Today, we will be shedding light on the complexity of diagnosis and treatment in personal injury law. A complexity that is often belied by the cookie-cutter approach that pervades the industry. In the legal field, every lawyer is obligated to adhere to the same statutes, but we know that two different lawyers might interpret those statutes completely differently. While using the same laws, an adept lawyer who continuously educates themselves with case law, for example, may receive a much greater settlement proposal than a less experienced or skilled one might. Clients benefit from having a lawyer who can analyze laws, see a vast array of possible interpretations, and determine what is truly best for each situation. This is because, as you know, a statute is not written for a specific case. It's a general principle that can easily be misunderstood by someone who does not have the experience or skills to apply it. And it might be something that two lawyers interpret differently in any given situation. The same thing happens within the field of medicine, and especially within mental health. There are standards for diagnosis and treatment, but two different practitioners could easily come to two different conclusions. And of course, a patient will benefit from having an expert with the experience and skill to interpret the standards in a deep, nuanced way that promotes healing and growth. Imagine a patient presents with pain in their arm. The doctor performs an X-ray, and it shows a fractured elbow. Without being a medical doctor, most of us can pretty easily understand what a fracture is. We can see where the bone is broken. It's easy to conceptualize, and doctors generally agree what treatment should follow. In this case, it would likely include a cast or sling until the fracture heals, and then physical therapy to strengthen the person and prevent further complications. In other words, it's not just about healing the fracture. Longer-term care through physical therapy is needed and expected. No educated doctor would say that just letting the fracture heal is enough. You let the fracture heal, but then the real treatment begins. Furthermore, a client who is young and healthy might have different needs than a client who is older with pre-existing conditions like osteoporosis. A person is entitled to comprehensive physical care even if they have related pre-existing conditions. What about a hip fracture? In this example, you can again see a bone that's broken, but the treatment is much greater than for a broken elbow. Here, a patient needs surgery and extensive physical rehabilitation, and then eventually physical conditioning. Insurance might cover a wheelchair, and then walker may be needed to aid the patient as they recover. The intensity of the treatment is on par with the intensity of the injury. Let's take one more physical example. A traumatic brain injury resulting in bleeding in the brain. What does the term brain bleed mean? Even as non-doctors, we can imagine what this means, but the technical term is hematoma or hemorrhage. The diagnosis is based upon taking imaging of the brain, and the treatment might be very intensive. It starts with healing the wound, which can involve medication and surgery, followed by long-term rehabilitative care with a physiatrist, OT, PT, SLP, and more. This is an extremely serious physical injury, and the treatment is appropriately intense and comprehensive. Now let's contrast these physical examples with psychological disorders. Let's think about a common diagnosis that we have all seen within our clients: major depressive disorder, MDD. You all know what a fracture is and what a brain bleed is, but what can you easily imagine MDD? According to the DSM-5, a patient has MDD if for at least 2 weeks, they experience a depressed mood or loss of interest or pleasure along with at least 3 others from this list: change in weight, sleep problems, feeling restless or slow, loss of energy, feeling worthless or guilty, trouble concentrating, or thoughts of suicide. About 2/3 of the individuals with MDD contemplate suicide, and about 10 to 15% commit suicide. Let's think about the diagnostic criteria for PTSD. In this case, you have a traumatic event, like an MVA, leading to intrusive thoughts, avoidance, and cognitive, mood, and arousal problems. This could include feeling sad, hopeless, worthless, and guilty. Sound familiar? It's the same symptoms we talked about earlier for MDD. If the symptoms can be explained by MDD, it's not PTSD. And if PTSD can explain them, it's not MDD. But of course, the boundaries of these psychological constructs are arbitrary. You could easily see how one psychologist might assign a label of MDD and another PTSD in a case like this. There are similar issues with disentangling physical from psychological problems. The average mild traumatic brain injury, known as concussion, resolves within 7 to 14 days. Yet, rates of long-term psychological disorders after TBI are quite high. For example, in a study of 18 to 64-year-olds, an entire year after a TBI, 22% were suffering with some psychological disorder, compared to 16% in the general population. 14% had a depressive disorder, compared to 2% of the general population, and 9% had a panic disorder, compared to less than 1% of the general population. If a person is diagnosed with a TBI, their psychological symptoms may not show up right away, or they may not be very intense right away, but it's likely that this person will need comprehensive psychological support. If they are only diagnosed with a concussion or post-concussive syndrome, this is really a misdiagnosis, and the patient may be missing treatment crucial to their recovery program. Let's now focus on what happens after diagnosis. As you know, for more than 50 years now, proponents of CBT have been touting it as the evidence-based therapy. Our clients who are found to have a psychiatric disorder are prescribed 12 to 16 sessions of CBT. This is the case whether they are found to have an adjustment disorder, MDD, GAD, PTSD, or a specific phobia. Remember how a hip fracture received more intense treatment than an elbow fracture, and a brain bleed received more intense treatment than a hip fracture. But here, whether a client is just feeling shaken up after a traumatic event, or whether they have a severe, debilitating mental illness, the prescription is exactly the same. And no reasonable psychiatrist or psychologist thinks you can sufficiently address a serious mental illness just with 12 to 16 sessions of CBT alone. It would be as ridiculous as giving someone Tylenol for a brain bleed. CBT is a manualized approach, meaning that CBT therapists follow predetermined lesson plans covering a small number of sessions. Why are prescribed, evidence-based treatment methods often ineffective? Well, studies have demonstrated that more than half of the effectiveness of therapy is based upon rapport between the therapist and client. Rapport is by far the greatest predictor of therapeutic success. This should not be surprising. To have effective therapy, you need to be able to be open and vulnerable with the therapist, and you can only do that if there's trust. The same is true within assessment sessions as well. If a client doesn't trust the assessor performing the assessment, they won't be able to speak authentically, and information crucial to accurate diagnosis will be missed. So think about what happens in our case of a client who is going to be assessed by a stranger, whether it's a Section 44 or 25. The client may have no understanding of the process or what to expect. They may be scared or skeptical. They meet with this person who doesn't know them at all and have a short period of time to diagnosis and decide what's best for them, even though, remember, it's not straightforward at all to determine whether a person has MDD or GAD or a specific phobia or PTSD or doesn't meet criteria for any psychological disorder. To make matters worse, think about the idea of a Section 44 examination, when the client is required to meet with the insurance company's psychologist or psychiatrist. They know this person isn't on their side, and they know this person may have the power to deny them coverage. Understandably, they can't communicate their feelings properly, and maybe they even amplify their symptoms so the psychologist or psychiatrist will believe them. or they are too nervous or ashamed to open up at all, and they don't share what they're going through. After this nerve-wracking process, a client and therapist are randomly matched. The client may have no experience with therapy and no understanding of how it works. They may be feeling apprehensive and uncomfortable. Considering the average person would not share what they are going through with even their closest circle, how can we expect a client to feel secure and comfortable to share with a therapist that was assigned at random? If half of the effectiveness of therapy can be explained by rapport between the therapist and client, how can anyone expect results when the client has no say in the process or who they build a therapeutic relationship with? I invite you to think of a time when you felt stuck. Maybe it was a time you were not happy in a relationship or just felt like you were in a rut. And then think about when that situation changed. That moment when you realized that you were not stuck anymore, and you had choices and tools to navigate those choices so you could move toward the life you want. If you take a minute to think of an example like that for yourself and feel what that shift in mindset felt like for you, you will realize this is what comprehensive care can do for a client. This is what you can do for your clients. So how do you go about it? Just like we don't expect a scrape, a cut, a bruise, and a fracture to all be treated with a cast, we cannot expect the prescribed treatment for a phobia, GAD, MDD, and PTSD to all be the same, as it currently is with CBT. Clients need to be evaluated by a mental health expert who are familiar with all the complications we've been talking about, and who will diagnose and prescribe treatment on a careful, considered, individualized basis. This might include CBT, or it might include other forms of therapy such as somatic, mindfulness, art, or music therapy, and behavioral therapy to focus on providing an individualized functional restoration program. It might include group therapy, retreats, or inpatient treatment programs. It might include yoga, meditation, and it might include work with a dietitian, because of course mental health and physical health go hand in hand. With this individualized approach, the key to success is again the rapport between the client and their providers. Without this bonding connection, we cannot hope for the client to be engaged in their own recovery. For patients diagnosed with MDD, about half relapse after one episode, 70% after a second episode, and 90% after a third episode. A third of GAD patients relapse. 80% of PTSD patients relapse. A client with previous trauma or previous mental health conditions may have a more severe reaction to their accident, and the treatment needs to address this severity and complexity. And once a client has one of these diagnoses, they may need lifelong care, since relapse is so likely. Do you see this scientific evidence reflected in the reports that you see every day? Clients also need a structure that will support them in creating a healing lifestyle. Imagine a client is told they should be eating plenty of vegetables, but they can't afford to buy fresh produce, or they can't make it to the store, or they have never eaten vegetables as part of their diet and don't know how to cook them, or they're depressed and want to self-soothe by eating ice cream for dinner every night and aren't motivated to cook. A treatment plan needs to take into account steps for helping clients overcome all these hurdles. This might include sending fresh meals to their home, so that their default is to eat these healthy meals while they're in a state of crisis and don't have the emotional bandwidth to make healthy decisions. All this needs to be considered when developing a treatment plan. Another key to success is accessible, abundant opportunities for education. After a physical injury is healed, a person might need a gym membership so they can maintain the progress they have made throughout recovery and prevent deterioration. Similarly, people need continued, cost-effective educational opportunities. Educational workshops will give the client an opportunity for personal growth, to maintain progress they made, and work on meeting their goals. For example, many of us have heard that meditation is good for us. But how many of us have seen the research supporting meditation? How many of us understand how and why meditation works? And how much more likely would someone be to commit to a meditation practice if they had this education and believed it would work? How many patients go into therapy seeking a quick solution to how they are feeling without understanding everything we've been talking about here? And how much more engaged might they be with education to support them? Industries are evolving, we as people are evolving, and so are our clients and their needs. There is no time like the present to help support and empower them as individuals with approaches that are built around their needs. Q Medical and eClinic United Healing currently serve 400 clients with predominantly catastrophic mental and behavioral impairment. We are proud to have a team of 228 healthcare providers who work individually and collaboratively support our patients' complex needs. Our companies were built around our understanding of the complexities of the whole human. We continue to innovate and develop services to serve and support our legal clients. Thank you for sharing your time with us today.